On behalf of Region 7 and the ASPR Respect Supplemental Grant, we want to welcome you to our series of interviews focusing on the perils and pearls of lessons learned regarding COVID-19. Our hope is to share the lessons our colleagues have learned and to assist you with your healthcare journey during this pandemic. Thank you for listening.
Good afternoon. My name is David Brett Major. I'm a faculty member at the College of Public Health at the University of Nebraska Medical Center and part of the faculty team with the Global Center for Health Security, and very excited to be interviewing Dr. Rao from CDC today. Dr. Rao, could you please tell folks a little bit about who you are and where you work and how you came to be involved in monkeypox?
Yeah, great. No, thank you very much. Thanks for inviting me here. I'm a medical epidemiologist here at the Centers for Disease Control and Prevention. I'm an infectious disease trained physician. I've been here at CDC for a little over 12 years, first as an epidemic intelligence service officer and then as a medical epidemiologist since then. And for the last several years, I've been working in as a medical officer in the pox virus and rabies branch. And one of the big things that I've been doing is leading the ACIP work related to rabies and orthopox viruses. I also happen to lead the monkeypox investigation that happened of an imported case back in July of this year.
You are the perfect person to torture with a whole bunch of my uninformed questions. I knew that we were going to have this conversation, and so had to brush up on my more recent monkeypox literature and realized that I really do have several questions. And so I really appreciate you joining. Thank you. And in addition to this being openly available, one of the reasons that we have this series is to convey aspects about threat and risk relevant for medical centers that may experience a sentinel case presentation. And so they're always, of course, thinking about healthcare worker protection issues, making sure that safe and effective care happens, and being able to participate in appropriate, diagnosis, referral, and after action, and feed public health information. So you said that you do ACIP stuff, and so maybe that would be a fun place to start, because I know it can be quite the topic. Smallpox vaccines, recombinant versus ACAM 2000, and protection against monkeypox infection following occupational exposure. Thoughts?
So our current work with the ACIP for orthopox viruses is about Jynneos, which is it's a relatively newly licensed vaccinia virus that is a non-replicating virus. So that separates it from one of the ways that it's different from ACAM 2000, which is prior to Jynneos' licensure, the only vaccine available that's licensed in the U.S. to prevent smallpox. So Jynneos is a non-replicating vaccinia virus, and so for that reason, it's sought after, I guess, because there isn't some of the risks associated with it. There aren't some of the contraindications that are associated with ACAM 2000. It also is administered differently. It's administered through subcutaneous injection instead of the bifurcated needle, the multiple puncture wounds that need to happen with ACAM 2000. So we're in the process actually of presenting to the ACIP a lot of information about what is available for, is Jynneos comparable to ACAM 2000 for efficacy? What is the safety profile? How frequently should the boosters be given if people do start getting it? And then also whether or not people who previously got ACAM 2000 can be switched over to Jynneos. So those are all the topics that we're discussing with the ACIP, and we actually anticipate a vote possibly occurring as soon as early next month.
That's great to hear that's moving forward. I know that was a ton of work for your agency and others, but that's for smallpox?
Well, it's licensed. ACAM 2000 is licensed for the prevention of smallpox. Jynneos has actually been licensed for the prevention of both smallpox and monkeypox. The ACIP recommendations for ACAM 2000 was for all orthopox viruses, even though it was only licensed for smallpox. And the same is going to be the case for Jynneos. So the ACIP recommendations have been for all orthopox viruses, not just smallpox.
One of the things I thought interesting in trying to catch up with your literature space is differences in use of other novel smallpox vaccines and post-exposure prophylaxis against ACAM 2000, where it seemed like, and I ask this because we think about, okay, a sentinel case shows up with monkeypox, and for whatever reason, in consultation with you, in consultation with their regional referral isolation center, they come together, they decide to do post-exposure vaccination. I did see some literature that suggested that timing of that post-exposure vaccination may matter differently with different kinds of vaccines. Will that be part of what the ACIP considers?
Yeah, so sorry, do you mean different types of, depending upon the virulence of the orthopox virus that somebody works with, that there'll be different recommendations for boosters? Is that what
I saw some compare in European literature with platforms that are not up for discussion right now with the ACIP. It seemed like the replicating ACAM 2000 did a little bit better about preventing disease, at least in animal models, a few days out, rather than recombinants, for instance, that had to be given immediately. Do you think that'll be an issue with Jynneos at all? And how flexible do you think post-exposure prophylaxis will be?
So what we're doing right now with Jynneos is really specific to pre-exposure prophylaxis. There's a lot of questions about, there's more data that needs to be collected and evaluated to understand whether or not it would be immediately effective for post-exposure. For pre-exposure, from our ACIP work, we actually found in our evidence tables, in our grade tables, that there was a small benefit of Jynneos actually compared to ACAM 2000. So at a minimum, they're comparable to each other, and best case scenario, if you can rely on the randomized controlled trials that were done, there may even be a slight benefit to Jynneos over ACAM 2000. So we don't think that's going to be a problem. We are not suggesting a preferential recommendation of one of these vaccines over the other. They're both going to be available. It's always good to have two vaccines available especially for a biothreat. And so we expect both of them to be available. For post-exposure prophylaxis, there's definitely a lot more discussion needed before Jynneos can be used here in the United States. I do know that it has been used in the UK, and the manufacturer says that there is some data from that experience. There is some animal data, but at this time, ACAM 2000 is what we recommend for post-exposure in these sort of situations, and it is what we offered in July when this case of monkeypox happened in the US.
So as strange as it seems, Captain, to say after a vaccine discussion, and that was super helpful, thank you, to go to say that, let's go to something actually a little more complicated. Sentinel case arriving at a distributed healthcare facility. How is monkeypox transmitted?
It's transmitted from, people can get it from animals, or from any other infected people. They can get it if they make contact with the bodily secretions of an infected individual or handle any other contaminated surfaces like bed sheets, for example. They can also get it if they're within 6 feet of somebody who is infected. So basically droplets, respiratory droplets. And that is how people get it, through contact or through droplets. You
knew right where I was going with this, and in terms of healthcare facilities, thinking about the level of precautions. And so this is the idea of droplet, and the idea that in some settings it sits, like we've learned with SARS-CoV-2, that of course droplet in more dispersible forms lives on a spectrum. This is relatively new knowledge, isn't it, over the outbreaks in the last few years? Could you walk us back a little bit and help folks understand why we think that this is the case, that in certain settings where folks are compact with high exposure, we need to be thinking about respiratory receipt of the pathogen?
Yeah, I mean, I think a lot of what we know about monkeypox comes from a whole lot of experience and a whole lot of research that's been done with smallpox. So smallpox and monkeypox are two infections that are actually caused by viruses in the same family. So smallpox is caused by variola virus, monkeypox by the monkeypox virus, but they're both orthopox viruses. And so they're similar in many ways, and everything that we know or everything that we recommend as far as precautions go really comes from the smallpox experience. Knowing how it was transmitted prior to smallpox being eliminated, has informed how, our recommendations for monkeypox. So that the whole droplet and contact comes predominantly from the smallpox experience, but is corroborated by experiences that we have where monkeypox occurs commonly, which is Central and West Africa.
So a healthcare facility has a case of an individual either from the Congo Basin or from West Africa where they saw something on ProMed or they saw an alert from CDC or State Department that said that this could be a risk for travelers. And the individual has an influenza-like illness and happens to have been active in a community where one might expect such risk to be present. And maybe there's a nondescript lesion starting on a palm or a sole. And so what is there in your mind? We teach identify the possibility of a threat, isolate and inform, call us, call you. Once they do that, what do you see as their first steps?
So once they recognize that what they're dealing with is monkeypox or could be monkeypox, as you said, contacting state health authorities, and the state health authorities will contact CDC. That's critical. After that, obtaining specimens, and there's some detailed instructions for how those specimens might be adequately obtained on our website. But once those specimens are obtained, they can actually be tested at a reference laboratory, probably a local, your state laboratory, your state health department laboratory, to evaluate for whether it's an orthopox virus at all. Now, if they confirm that it's an orthopox virus, then the specimens should concurrently be sent to CDC. But after they confirm that it's an orthopox virus, the testing at CDC will confirm whether or not it's monkeypox. And that testing is only available at CDC. They can also determine which clade of monkeypox it is. And the clade actually does have implications on understanding the potential clinical severity, where it might have come from, but also, for example, the management of the patient. Category B waste is the West Africa clade, whereas the Congo Basin clade is category A. So it has implications, all of that testing, and it can happen at CDC pretty rapidly. Ensuring that the patient is in a room where droplet and contact precautions can be maintained, and that it's strictly monitored who is walking in and outside of that room, so that they can be monitored for 21 days after the last exposure to the patient, and ensuring that everybody who walks in and out actually is wearing the appropriate PPE, which at a minimum would be a gown, and gloves, and a mask, and then depending upon the additional procedures that are being done on a patient, standard precautions. So if they're performing a lumbar puncture, for example, then they need to follow the typical processes for performing a lumbar puncture and wear eye protection, and in addition to the gowns, gloves, and masks that they're wearing. That would be where we would start, I would say.
No, I think that describes that makes sense to me. And then if the patient is critically ill, there's a possibility of urgent intervention with aerosolization or intubation. You might suggest an airborne isolation room?
Yeah, so the airborne, we say that if at all possible, it would be good to keep such a patient in an airborne isolation room as well. And that's really just based on, like you said, just the off chance of there being an aerosolization because of a procedure or something like that. So if at all possible, it would be good to put the patient in a room that enables that there is no aerosol transmission to others, but at a minimum contact and droplet.
Walking back a moment to identifying the case, I noticed that literature, not just CDC's, but others, goes with the universal all viruses show up within 21 days for the most part. Giving a think to the case that you saw in Texas, other outbreaks that have occurred local or in the United States, in your experience, especially in DRC and in Cameroon, what are your thoughts on actual incubation period? We say these things about Ebola, right? But almost all Ebola cases end up having had an exposure like 8 to 10 days beforehand. How should we think about it in a more nuanced way?
Yeah, there's never been there's never been a case that has occurred more than 17 days after an exposure. And so we go with 21 really just to be as conservative as possible. We felt that once we were past day 10 or 11 or so, that we were likely in the clear, because with each passing day, the chance is lower. But of course, 17 days is when we really felt much more relaxed, and 21 days was our rule for being relaxed. We weren't concerned beyond 21 days because there's never been a case that has occurred more than 17 days after.
That's actually a super point. So big, bulky, slow replication virus, slower than we think about with some of our faster onset threats. And we really should be thinking more about that 21-day window from what you're saying.
Yeah, they certainly, people should be monitored very closely. And there have been situations where secondary infections begins or is first noticed several days after the first patient was hospitalized.
Thoughts about near-term complications that require escalated care. So once an individual like that comes to one of our designated biocontainment units, it less of a concern in the sense that we happen to be resourced to do advanced procedures and other sorts of systems of care support for critically ill patients. But for the hospital waiting to transport somebody that is suspected or confirmed to have monkeypox, are there usual in the first couple of days of diagnosis complications that might make their situation more challenging?
Yeah, we worry about just fluid loss in patients, just because they can act like burn patients in some ways because of all these lesions all over their body, and they're going to need potentially fluid repletion and close monitoring of their vitals for that, because of that. There's also no specific targeted treatment as such for monkeypox. I mean, there are antivirals that are licensed, like tecovirimat, and there's brincidofovir, Tembexa as well. The use of those has been pretty limited in patients in human patients with monkeypox. But they're available through consultation with the CDC. We do have an investigational new drug protocol for those available depending upon the severity of the illness. But mostly it's supportive care that a patient needs. And so close monitoring, close oversight, it might be particularly important during the first few days because of that fluid loss potential. Fluid loss aside, as time goes on and these lesions are progressing, so they go from vacuoles and papules to vesicles, and then pustular lesions, and finally scabs that eventually fall off. And that can take several weeks for it to complete from beginning to end. The patient's skin sloughing on the ground, proper care, maintenance, making sure that's all cleaned up. So that from an infection control standpoint, from a nursing standpoint, ensuring that you have staff dedicated to this one patient, those can all be resource intensive. And so for a hospital setting, unlike yours, like a regular hospital that's dealing with a lot of patients, especially right now during the COVID pandemic, it can be challenging to provide all of that care that's needed. Another consideration is that if specimens are sent out elsewhere before the patient's diagnosis was confirmed, like to a send-out laboratory, then that laboratory needs to be made aware of the fact that this patient has been diagnosed with monkeypox and ensure that the facility that does that send-out testing, similar to their own laboratory, is wearing the proper personal protective equipment while handling those specimens. Because we'd hate to have an exposure happen like that from a laboratory setting. Those are all things to look out for.
That sounds very prudent. My sense from the CDC documents, your documents, was that while you can certainly capture viremia, is it true though that the viremia risk goes down substantially once lesions are present? I'm thinking the laboratories obviously have to be vigilant, but it is a deliberate response for a laboratory that happens to have handled specimen rather than necessarily in a short fused emergency to be able to risk characterize and assess their level of exposure. Would you say that's true, or how would you think about it?
How would I think about risk exposure?
About the ways to think of it. So I'm a sentinel case receiving facility. My lab, they already had lesions. My laboratory turns out to have run a CBC. What's the level of stress that should be happening, even though they have to be deliberate to chase the exposures?
Yeah, the level of risk is low. Like you said, it's not the same as Ebola. It's not like someone handling Ebola specimens. The risk is low. We'd still want to monitor such individuals for 21 days, particularly if they weren't wearing the right PPE, but the risk is low.
I also noted in your work that the case fatality rate you've been seeing in the Congo Basin can be over 10%, but in referral settings where travelers have come back to the States, or we've had local zoonotic exposures with good systems of care, what's our case fatality rate look like?
Problem is that the case fatality rate really is going to depend on the individual who's been infected. For individuals, for example, who are pregnant or who have an immunocompromising condition like HIV, the risk for death is probably a lot higher than a healthy individual, for example. So it's hard to really specify what the risk really is. I would say the risk is higher, certainly for people who are pregnant or immunocompromised. With the smallpox vaccines last being given many decades ago at this point, people's protection and immunity against is low. And there's a lot more people who are immunocompromised now than there had been in the past. So the 10%, I think, is the closest number that we have right now, but that's without truly knowing how extensive monkeypox really is.
Have we lost individuals in the US who were escalated to high levels of care?
No. So in the United States, before this case that occurred that was brought to the United States from Nigeria in July of this year, there were some cases that occurred in 2003. Those were due to imported mammals that were brought in from Africa and were housed with other animals that were brought in and taken up by families as pets. And so there were several persons who were infected during that outbreak back in 2003, and this is the only other time that there have been U.S. cases.
I feel like I have another half hour to hour of questions for you, but I know that we're reaching the end of time. Dr. Rao, thank you for joining us. What would be your parting thoughts on how hospitals that might receive a sentinel case and be thinking about that scenario, how they ought to think about monkeypox services, opportunities, and looking forward?
Yeah, I think the right thing was really done in this particular case that happened this year. The clinician in the emergency room immediately recognized that something unusual was taking place just because these lesions are so unique in appearance. They are these deep-seated lesions that are all over the body, particularly on the face, on the extremities, on the palms and soles, like you said. And even though he was not familiar with monkeypox, apparently he did a Google search. I recognized that it could be monkeypox and immediately called his ID consultant and said, I think I have a case of monkeypox. And so diagnosis, I would say, is one of the key things, just making sure that you're alert to the possibility of something serious and immediately putting a patient in the right precautions needs to happen. And that is what happened in this case. And that's what prevented a lot of secondary infections. Another thing that helped prevent a lot of these secondary infections was masks. There were a lot of people on airplanes that were monitored for 21 days, but the fact that masks are being used a lot right now probably played a big role in preventing any infection transmission as well. So I would say diagnosis and following the right infection control precautions are really important things to consider if any hospital has another case like that.
Great. Well, thank you very much.
Thank you.